So good afternoon, everybody. Welcome to Boston's ongoing non-spring. For those who I don't know, I'm Sandro Galea, and I have the great privilege of serving as Dean of the School of Public Health at Boston University. And welcome to our monthly Public Health Forum. This Public Health Forum are opportunities for us to bring leading scholars, thinkers, and doers who really are grappling with the most important public health issues of our time. And today we have really somebody who is very special in that space. Before I introduce our speaker, let me just make a comment about a program that we run at the school, which we like to commemorate every year, roughly around this time, which is our Community Scholars Program. So the Community Scholars Program has been happening in the school since 2000. It was launched by my predecessor, Dean Bob Meenan. And it really is a program for experienced public health professionals who receive scholarship support to pursue their MPH while continuing full-time employment. We select people very carefully, and we take really only the best to this. And the idea is that our scholars bring expertise to enrich the classroom research and life of the school. The community scholars benefit the student. They get financial resources. It benefits their agencies because they benefit from employees who are bolstering their knowledge and skills, and it benefits us because we have real access to smart, committed, experienced students who broaden the diversity of our student body. In the 18 years since the program started, the program has supported more than 165 scholars, 17 of whom are currently getting their MPH degree. We have several scholars today. Can you all stand up and just wave? And today, we simply wanted to acknowledge the scholars, say thank you for what you do, and thank you for being part of our community. And afterwards, you'll have time to talk to the scholars afterwards. And I want to acknowledge Professor Ann Fiedler, who really coordinates the scholars program. So thank you all for joining us. We thought it was particularly fitting to have the community scholars celebrated and noted with today's Public Health Forum because of our speaker. So let me formally introduce our speaker. Our speaker is Dr. Ann Schuchat. Dr. Schuchat joined CDC in 1988 and has served in various leadership positions there over the years. She currently serves as CDC Principal Deputy Director. She assumed this role in September 2015. She served as Acting Director of CDC from January to July 2017, and then again another 4 months recently. And she has been Director of CDC's National Center for Immunization and Respiratory Diseases from 2006 to 2015. Dr. Schuchat has really lived a life of action within CDC. She has played key roles in CDC emergency responses, including the H1N1 pandemic response in 2009, the 2003 SARS outbreak in Beijing, and the 2001 bioterrorist anthrax response in the United States. She has worked globally on meningitis, pneumonia, Ebola vaccine trials, and conducted surveillance and prevention programs in South Africa. She graduated from Swarthmore and the Dartmouth School of Medicine, and she was promoted to Rear Admiral in the Commissioned Corps of United States Public Health Service in 2006, earning a second star in 2010. Now, that's the official biography. Now, the unofficial biography, if I may for 2 seconds, is that Dr. Schuchat is really one of the most thoughtful public health leaders this country has. Anne probably doesn't remember this, but we first met in 2008, and she presented, and I presented after her at the American Epidemiological Society. And it's one of those times when somebody presents and you're like, oh, I'm so doomed, because the person before you is smart, thoughtful, and actually doing important work. And I feel like Dr. Schuchat has done that throughout her whole career. It's really a privilege having you. Anne.
Well, thanks for that warm introduction. And I actually have to say that having had to follow you since then on speeches, I am not so sure I'm up to this. But it's really a pleasure to be here. I tried to come in January, and it was actually weather in Atlanta that interfered. I felt like such a wimp because the Atlanta airport was closed when we had about this much snow. But I'm really glad to get to be back here today. I really hate emergencies. I like to plan ahead. I like to be in control. And it seems like I have spent the past almost 30 years at CDC in one emergency after another. So I was keen to get to reflect a little bit about crises, calamities, and chaos, and how we could do better in them and learn from what we've experienced. Last week I was at an event about predicting and preventing epidemics, and a lot of the discussion was about how we had to take more advantage of the inter-epidemic period to get ahead of these things. And I realized that our perspective at CDC is we just really want to have an inter-epidemic period. So one of the ways that we try to address epidemics or emergencies at CDC is by learning from fighting fires. There's actually a whole science to how fires are fought. And although the culture of firefighting and the culture of public health are really different, the strategy of firefighting was actually imported into CDC and now to a lot of health departments around the country to help us get better at these emergencies. So the way that fires are fought is with something called incident command systems or structures. And the principle here is to have a system that can allow people who have never worked together, who come together in the midst of a problem like a wildfire, and to empower the lowest level or the front line of the response, but to have a way that the information that that front line is experiencing get to central authorities and can be learned from, and resources and adaptation can follow. And so the basic structure of a fire response incident command involves operations, planning, logistics, and finance. And this is something we take courses on so that we can adapt it to the emergency response. Over the years at CDC, we've been evolving how we plug ourselves into this. And I just want to show you the way that incident command worked in the 2009 pandemic. Most of the colors on this, the green and blue on this slide are the traditional parts of the incident command structure, but the red is the scientific units. There were that many different little scientific boxes or teams that had to help respond to what the state and locals or international or clinical partners needed. And so those technical specialties really make fighting a fire and fighting an influenza pandemic very different, and yet the structure and systems from the firefighting can be helpful. In Atlanta, we now have a really nice-looking emergency operations center, but even before we had an emergency operations center, we were trying to use this system to efficiently deal with a lot of chaos. The principle of emergency response involves both protocols, where you operationalize all the planning you've been doing, practicing, where you do exercises or tabletops or simulations, and really test a huge range of scenarios. And then the people involved, who ideally are identified in advance with particular roles that they're going to play, and a chance to practice and develop out what skills they're going to need and what they're going to be doing when that crisis hits. After the avian influenza emerged in the early 2000s in Asia, CDC, state health departments, and a lot of ministries of health started to prepare seriously for a pandemic of influenza with a lot of drills, a lot of activities. Some of you were probably involved in that here in Boston, or perhaps at the national or state level. I have to say that within the first couple weeks of the 2009 H1N1 pandemic, people kept talking about it as an exercise because we were so used to practicing and drilling for a possible pandemic. But when the actual pandemic occurred, it was not at all what we were expecting. And yet that practicing was helpful. I visited Colorado a year after the pandemic and met a public health nurse who told me about the vaccination program in her county. She described that she had been practicing and drilling and was supposed to be the incident commander for that immunization effort when we got the pandemic vaccine and were finally able to administer it. So she said they were doing it at a football field, and the thing was supposed to start at 8 in the morning. And so she got to the venue at about 5 in the morning to help set up and help get her team, to go through the last minute training. She got there and she saw hundreds of people already there, just a sort of mob environment. And she looked at the place and she thought, OMG. She stepped away and she thought, she kind of had her panic moment where she realized, I'm in charge of this scene and this scene is not starting out very well. But she took her couple deep breaths and she realized that she knew what to do, that she had trained, that there were protocols, that her people were trained, and she returned to the scene and they had a very successful day. I think one of the things that happens with preparing and training and exercising is you realize that you really can do more than what you thought you could do. So she was really proud of what she'd been able to accomplish, and I think even surprised herself. I think one thing that might surprise you is just the scope, not even counting the state and local public health or the clinical world or the international partners, but just the CDC staff that have been involved in some of our recent responses. In the H1N1 influenza pandemic, the Ebola activation, and the Zika activation, our staff have been engaged for more than 12 months. We've had thousands of people engaged. We had 1,900 staff deployed to West Africa during the Ebola response. And we've had thousands of staff involved with Zika coming from every part of our agency. So the complexity and the duration and the scale of these responses is not what most of us expected to be doing in the past several years. One of the biggest challenges in these events is to address that spectrum between being extremely rigid and total chaos. How do you not follow the plan when the plan doesn't make sense, but not get complete anarchy to take over? So we have a few things that we try to go back to, and very similar to a busy emergency room or perhaps a very raucous party, but we try to remain mindful of the strategic vision, what we're really trying to accomplish, and focus on executing that vision capably. That involves empowering the command structure to actually get the job done rather than micromanaging or having everything need to return to the highest level. And it also involves learning every day. We formally do that with some in-progress reviews, with identifying key metrics that we track and religiously, and then by learning at key points after the response. I think it's true that public health emergencies always differ from what we've trained for, and that more and more today, with the complexity of our world, these end up being marathons and not sprints. And so we have to plan for that and staff for that from the beginning. And a theme in what I'm going to talk about is the theme of expecting the unexpected. Because just as soon as you think you know where things are going, they change. So with that idea that the unexpected is to be expected, I next want to turn to the information that you have, this sort of fog of war. I'm sorry for all these military analogies here, but the issue of uncertainty is extremely common for most crises. The two ways that people have thought about planning in emergencies are shown here, with General Patton saying that a good plan violently executed now is better than a perfect plan next week. And there are some things that is actually true for, versus a cool judgment is worth 1,000 hasty counsels. The thing to do is apply light and not heat. And there's many times that is true as well. Unfortunately, I have never been in a time where one or the other of these is all that you have to worry about. So I want to tell you about the first few days of the 2009 influenza pandemic. On a Tuesday morning, CDC issued an early release in our Morbidity and Mortality Weekly Report describing 2 children in Southern California who were totally fine but had recovered from respiratory illness where an influenza strain was identified that was completely novel to people. It had swine origin. The children were fine, but these were novel strains, and we just wanted to know, was there any more of this out there? So we did this early release, Tuesday morning. On the Thursday afternoon, we had learned of 5 additional cases of this unusual novel strain of influenza. We held a press conference that afternoon. It was one of the most unusual press conferences that I've been part of. We had 7 people now who had this novel influenza strain. They were all better, only one of them had been hospitalized. Half of the reporters wanted to know, why are you having a press conference? And the other half of the reporters wanted to know, is this the end of the world? We had primed the journalists and a lot of the public community to be ready for a pandemic, and this sounded like perhaps one was starting. But we didn't really know whether this was nothing or this was something. That Thursday night, we got a call, actually a series of calls, that alerted us that severe illness in Mexico had resulted in virus specimens being sent to Canada, where genetic sequencing revealed the exact same swine origin influenza strain that we had been identifying from these mild patients in California associated with deaths and severe pneumonia in Mexico. Friday, during the day, we learned that there was a school in Queens in New York City where a couple hundred kids were out ill with respiratory illness, and it sounded like the very same thing that we were dealing with in California. So we went from 2 new strains, probably nothing, to it's out of control in New York City and in multiple other states. The early days of the pandemic, there was a lot of incoming data that was very difficult to understand and sift through. The week after our alert came in, we'd encouraged individuals to test for flu and to look for the typing, and if it was untypable, to get the specimens to the health department so that we could figure out what was going on. You can see that there was an 8-fold increase in specimens being tested just after our alert. You can also see in orange the specimens in that most recent week that were the pandemic strain. But notice how the majority of specimens that week were not the pandemic strain. The 2009 pandemic emerged in the middle, or towards the end, of seasonal influenza. And that's really why in Mexico, when they first started testing strains from severe illness, they kept coming up with seasonal flu. The pandemic was the needle in the haystack of seasonal flu, and you needed a sensitive system to find it. So we had conflicting information. We had severe disease in Mexico and mild disease in the US and out of control disease because the virus clearly had learned how to be efficiently transmitted. We think about a pandemic as a novel strain that we don't have population immunity to, that can cause severe disease and that is efficiently transmitted person to person. So we seem to have all the elements of that. Much of our pandemic planning had involved the worst case scenario, the 1918 type of flu outbreak and the bird flu strain in Asia. And so we had planning that involved pretty severe measures to be taken to try to mitigate the illness before we could get, the definitive types of measures like a vaccine. So early on in the response, when schools identified students with a pandemic strain, many schools closed or students were dismissed. It's amazing to me now that it was only about 10 days between that beginning Monday, April 27th, and the peak of almost 600,000 students being dismissed from school and more than 1,000 schools having closed, that it seemed in retrospect like it was a year that we were dealing with these school closures. But it was just really less than 2-week period where our measure of suggesting until we know more, students should be dismissed, to what a stupid idea, that's really inconvenient. You can see that once we were able to update our school recommendations rapidly, things got back to tolerable. But we learned at this point that taking extreme measures like closing schools had many second and third order consequences. Parents had to stay home, offices and businesses couldn't run because the parents were home, and we didn't know yet how severe the strain was. It seemed like that was a lot of disruption for a lot of uncertain benefit. One thing that we did based on the 2009 pandemic was update the playbook and updated the plan so that we weren't going to always expect that we will, institute extreme measures like closing schools when we have the first sign of a pandemic, but that we will do assessment of severity over and over and over, and that our mitigation measures like school closures would adjust to what we were learning. It turns out to have effect, you need to close schools early, but to not be disruptive and to have people put up with them, you need to be pretty sure that it's worth it. And so with the initial information, we really didn't know. The other update to the newer pandemic guidance is about the importance of communication and public outreach. No matter how much you do, you really need to do even more. So I don't have all the answers to how to deal with the fog of war. I can tell you it's important. One important tool, though, is to acknowledge uncertainty. The early actions might be needed to be effective. They may not be well tolerated, but you need to frame them as efforts that are interim and that more guidance will come and that you'll update as soon as you can, and frequently update to keep the public with you. I think a key point for this audience is how important it is to invest in surveillance and data systems so you actually have better data. That's not that easy, but it's really important. The last several emergency responses we've had have told us that things are not always as they appear, and that we really do need to be ready to be deceived. We thought that we knew Ebola. The first Ebola outbreak, the virus was first recognized in 1976, and there had been dozens of outbreaks since then, and the world global health community thought they knew Ebola, but we did not know what Ebola could do in certain circumstances. The 2014-15 epidemic involved 10 times more cases than all of the 40 years of Ebola that we'd been through before. It was the first time that this virus had reached dense urban populations in the 3 countries in West Africa, and the first time that we saw spread in the United States or in countries in Europe. Very limited spread, but not what was expected. It was also the first time that the biomedical community was able to launch a large-scale field trial, multiple large-scale field trials of investigational vaccines in the middle of an epidemic. As quickly as those of us involved with these trials thought we got these trials launched, it was after most of the disease had passed. And so with heroic effort, Guinea, Sierra Leone, and Liberia launched these 3 big trials, but yet it was too late to really have a major impact on the trajectory. One of the things we've learned is that our foes can change. We've been dealing with mosquitoes at CDC since our founding in 1946, but what we learned in 2015 and 16 was that they can take on new ammunition. Nobody expected a mosquito-borne virus to lead to birth defects. Nobody expected a mosquito-borne virus to be sexually transmitted, but that's what we had. And so with the Zika epidemic, we had a whole new emergency response. We're used to deploying drugs and vaccines and personal protective equipment in the middle of emergencies. We were not used to deploying contraception as a critical countermeasure for people who were trying to avoid pregnancy until the risk was clarified. But we were able, working with partners in Puerto Rico, to establish something called ZCAN, which was reported in Lancet Public Health in January, which reached tens of thousands of women in Puerto Rico with reversible, long-acting contraception based on training of clinicians who hadn't actually had access to those tools and donations from a number of partners. We also hadn't had emergency responses on a large scale in the modern era that needed such close collaboration between communicable disease groups and birth defects or maternal and child health groups. One of our initiatives during the Zika response was the local health department initiative, where we were able to place staff in a number of local health departments to help build those bridges between those caring for women and babies, the communicable disease folks, and the partner organizations that could help connect the dots. So how do you deal with these unexpected wolves? I would say we have to expect that more of them are coming. The environmental world that we live in is such that the factors that lead to these unexpected events are all increasing. Microbial adaptation and the problem with completely untreatable drug-resistant infections, environmental changes leading our ecosystems to put more people at risk, urbanization and globalization, and just the changing of the world's population, as well as the terrible devastation that we've seen with these large refugee problems. None of us were expecting big diphtheria outbreaks to occur, but we're seeing that in refugees who've arrived to Bangladesh. Terrible problems with cholera and a number of other refugee settings. So the threats are real and they continue. But there's some key lessons from these recent global outbreaks. Every country needs the ability to find, stop, and prevent epidemics. We call that the Global Health Security Agenda and have received resources on an emergency basis and enormous global public-private partnership to try to strengthen the capacity of every country to be able to respond and prevent epidemics. But beyond that, the lesson of Ebola was that we also need the world to be able to surge when necessary. So that involves governance that wasn't in place in the 2014 epidemic and changes at WHO, which are in progress. I'm not going to spend too much time on this, but Ebola and SARS and MERS and the problems of antibiotic resistance remind us how important infection control is, and that the big, splashy SARS or MERS kinds of outbreaks remind us of the day in and day out weaknesses that we have in infection control, which need to be addressed. Finally, for this section, the pace of research and development of countermeasures is not yet enough. We could congratulate ourselves for launching trials, but they weren't launched quickly enough, and we weren't able to launch the treatment trials in ways that could get meaningful information. After my almost 30 years at CDC, I would say that the area I think is the most important in emergency response is addressing the hearts and minds. Keeping the public with us and learning from the public, whether it's through communication, engagement, or involvement, is really essential. The public has limited tolerance for a single outrageous act. In 2001, when anthrax spores were sent in the US mail, we had enormous concern and very limited public health ability to message our response. In 2014, when a single humanitarian worker returned to Atlanta to be cared for, this is what the street outside CDC and Emory Hospital looked like. The public did not expect there to be patients with Ebola cared for in our backyard, and we were not very good at doing this at first. And when the truly cataclysmic occurs and hundreds of thousands lose their lives suddenly with natural disasters, the public need for understanding and information and real engagement is enormous. I got to have lunch with some of the students, and we talked a little bit about communicating in a crisis. I think this is really important for everybody in public health to know. In a serious crisis, people take in information differently, and they process information differently, and they act on information differently. So we have to communicate differently in a crisis. At CDC, we have this mantra where we want to be first, but we want to be right, and we also want to be credible. In 2001, during the anthrax response, it was really hard to get all three of those right. Now, with 24/7 social media and many, many other voices, it's even harder to be first, to be right, and also to be credible. But the strategy that we implement is what some of your professors teach you, is risk communication, where we try to listen, to acknowledge people's concerns, to help them be active and ask them to tell us what they find and be part of the solution, to be open and honest about what we know and what we don't know, and about what we're doing to fill in those gaps, to speak clearly, which is really hard for a lot of us doctors and public health experts, and to be compassionate, to not suppress our humanity, but to actually express it. Showing emotion when the circumstance calls for it is actually the right way to communicate during a crisis. But leaving people with something to do and actions they can take helps them regain control. I think it's really important that we engage and not just inform. And these are photos from our Ebola Sierra Leone trial to introduce a vaccine against Ebola. Pat Hibbard here chaired our Data and Safety Monitoring Board. This was one of the hardest things I've ever been part of, trying to work with communities to introduce a research study to test an investigational vaccine that had hardly been given to anybody in the middle of a raging outbreak. One of the reasons that we did have good partnership and good acceptance was we worked with the community from the beginning. So the last part of my remarks is about measurement, and I think this hopefully will reinforce what you're learning in class. We like to say that what gets measured gets done. Certainly that's what happens on your tests, right? So we know that in much of life, we do what we expect to need to do. We are trying right now to support and reinforce what we call the Global Health Security Agenda through a measurement and accountability framework. something called the Joint External Evaluation, or JEE, which has been developed to have a process by which countries can be measured, including developed and developing countries, in terms of essential capacities, whether they're going to be able to meet their international health regulations or not. And that it's not about making people feel good or bad, it's about identifying the gaps, helping the governments and partner donors and so forth fill the gaps with resources, and helping continue to measure and assess progress. It's intended to be transparent, independent, objective, rigorous, and standardized, and something that countries that aren't so sure about foreign aid can buy into because it makes all of us more safe. So measurement in general can improve the quality of care in healthcare, or the quality of public health as well. But measurement can be a dangerous thing as well. And I want to just mention the role that measurement may have played in one of the factors that led to the current opioid epidemic. In the 1990s, we had in the medical community a sense that we were under-treating pain, and some of the accrediting bodies and the measurement groups said, well, let's measure pain. And so people talked about what they call the fifth vital sign, like pulse and temperature and blood pressure. And so people were asked if they were in pain or not, and docs and nurses sort of started to treat to the pain. Perhaps not a surprise, we saw a huge increase in sales of opioids, prescription opioids, and unfortunately a huge increase in deaths from overdose from opioids. When we look across the country, the map of where opioid use is higher looks a lot like the map of where antibiotic use is higher. There's probably enormous practice variation county to county, but unfortunately by 2015 there was no state in the country that didn't have high levels of opioid use and high levels of overdose as well. But the opioid epidemic, like the influenza problem or the Ebola problem, keeps surprising us. The opioid epidemic we talked about a few years ago is not the same as the opioid epidemic today. The first wave is what I mentioned, that overprescribing and lots of overdoses associated with prescription drugs. But a second wave has occurred related to heroin. And a third wave that we're really struggling with today is related with illicit fentanyl use. This is a really sneaky phase because that illicit fentanyls can be in heroin, they can be in prescriptions, they can be in methamphetamine, and they're incredibly toxic. I saw the sign downstairs for training on how to administer Narcan. This is the epidemic of our time. It's really a crisis of our time. So I think whether you're in social sciences, critical care, or in epidemiology, there's a lot of work to do on this. So this just sounds pretty doom and gloom, but I don't want to leave you with that. There's some serious forces that we have to reckon with. What was global is now local. What's local can help us inform what we should be doing globally. We have an exquisite interface between people and animals right now that puts us at a lot of risk. The natural world and the man-made threats are important. But as much as I feel like the last several decades of my work has been dealing with catastrophes, I think one of our biggest threats is complacency. When you have emergency after emergency after emergency, it's hard for people to take you seriously. So we have to make sure that the public is engaged in the solutions and that we don't become sort of chicken littles. I think, though, that we can learn from these public health emergencies a few things. One is that good data are essential. Lots of promise with big data, lots of promise with electronic health records, and all kinds of, I just learned about the digital exhaust of all of our social media, but we really need to validate that good data and understand what it's telling us. Early detection, whether it's Ebola or influenza pandemics, makes it much easier to respond, much more effective response. But prevention is even better. And I think a critical final message is that emergent threats require multiple sectors. The opioid epidemic needs public health, but it needs public safety. Influenza needs human health, but it also needs animal health. Domestic issues are also global issues. So pretty much everything you're studying here at the School of Public Health is relevant. But besides what you're studying, besides your professional roles, I think that just like the forest fires, who you are as a person and who you are in your communities and your relations is also important, because only you can prevent forest fires. So thank you. So I think we have time for some questions or comments or rebuttals if anybody wants to ask anything. In the back, and then we'll come up here. Oh, we have microphones circulating too.
The experience of dealing with Ebola was certainly very difficult in West Africa. We certainly dealt with the issue of fear in this country. What would you have done differently when you reflect on how we ultimately responded to it in this country?
Thank you. It's so incredible, the contrast. You know, I live near where that photograph was taken in Atlanta, where the one patient just led to this enormous media concern. And CDC staff whose children attended daycares centers in Atlanta had issues about could they bring their children to school because their parents were coming back from overseas. There was just huge fear in Atlanta. When I traveled to Sierra Leone, some of you also probably were there, the billboard said Ebola is real, because people didn't believe it was real. You know, it was, the message there was, there really is a terrible illness that's, you know, killing people here. I think that communication is very important and trust is very important. In our work in West Africa, things didn't really change until it was the local leaders, authorities, community influencers who were out in front, and the West was not trusted. We do think that you don't build trust easily in a crisis. It's much better to be working there in advance, to have partnerships, to know each other. Here in the US with the influenza pandemic training, we were very big at having the hospitals and the health department meet each other. So you didn't first meet in the middle of an emergency. So I welcome suggestions, but I think the issue of trust and trusted spokespeople, maybe the other issue is signaling uncertainty. I think there was one comment that our former director made that was taken out of context that sounded overconfident. We're never going to have Ebola here, which was not exactly what he said, but it's what everybody heard him say. You know, what he really said was we're not going to have out of control, widespread disease like they're having in the countries he just returned from. But what people absorbed was it's no nurse who's caring for a patient with Ebola is going to get Ebola in the US. And of course, when nurses caring for patients with Ebola got Ebola, that was bad. You know, when the first African returning man, you know, was not admitted to an emergency room and then came back and died, that was bad. So I think the issue of humility, signaling uncertainty, signaling that we care and that we're with you. You know, people, you have this tendency to want to over-reassure if you're a spokesperson. You know, admitting that you don't know is actually a better strategy. But I can't say I could have done anything to avoid the fear that we had. Those are just some random thoughts. We had a question up here too.
Thank you very much for that. I thought that was a very sensible, well put together presentation, and I think public trust is absolutely essential, as you do, to effective public health. You also said some stuff at the beginning that I found provocative, and I don't mean this to be, well, I just like your thoughts on it. You seem a little hesitant about using the military metaphor, which doesn't include trust at all and doesn't really do anything except absolute planning. And it's kind of, well, a lot of people in the public health service are in the commissioned officer corps, as are you. And I just wanted to know what kind of message you think the public gets when you go on television as a rear admiral rather than as a physician. And I think physicians are much more respected in this country than military.
Yeah, thank you. I have this slide that I wish I'd brought with me, which talks about crisis communication and expertise and trust, and how audiences view different professions. And you know, when it's not a crisis, professional expertise is really high value. You know, so the professors, the white coats, and everything really high up there. When it's a crisis, empathy, compassion, honesty, transparency is where most of the focus is. So whether I'm wearing my uniform or not. I always try to have that compassion and openness and honesty. But I did a media training which kind of speaks to your point. It used to be, some of the folks here used to be also commission officers. In the old days, we wore our uniforms once a week. And then around 2005 or so, we were asked to wear them every day. So before the everyday uniform, I did this media training where I was getting my ID renewed. So I had my uniform on in the morning, and then I took it off in the afternoon and changed into casual clothing. And the media training was taping us. The people, doing, fake videotaping us as we tried to do fake press conferences and so forth. And the people who did the training told me, you should always wear your uniform when you speak to the press, because you sounded really good this morning, and this afternoon, I don't know what you were doing. So just that I sounded more credible to them. Whereas during the 2009 pandemic, I was one of the spokespeople. I was on TV a lot, and some of the people in the administration really wanted me to wear a cardigan and be more approachable, be more like, your neighbor. But, so I do try to clarify for folks who don't know, we are uniform but not military. A lot of the public health emergency lingo is sort of war lingo, for good reason and for other reasons too.
Thank you.
Uh-huh.
Thank you. That was terrific. Can you talk a little bit about communicating uncertainty? You went through it a little bit in narrative, but can you just guide us through what are the principles you're keeping in mind given the uncertainty that you face often, and how you're trying to balance that then with people trusting you without them, of course, thinking you don't know anything?
Yeah, the first thing is to overcome the thought that sounding certain is better than sounding uncertain. Because when you sound certain, you really open yourself up to be wrong. A lot of people who are highly educated were reluctant to, not know the answer. But admitting that you don't know, but you're going to get on it is helpful. There's a lot of pressure in today's world to simplify and to oversimplify. And can't we say it this way? Because it's easier for people to understand. And we have to both push back towards errors when you oversimplify and unintended implications. There was we had a big battle one Saturday. I want to write this up at some point and call it the art of the possible. But we had a big battle on a Saturday morning in the middle of the MERS response, where we had an individual who had been identified who possibly had MERS and had a lot of high-risk contacts. And we had this issue of how much can we be isolating or keeping him away from people, keeping his contacts quarantined away from other people before we're totally certain that he had MERS. And we had a big debate. Should we go to the public and tell them we were working this thing up, or could we get more information first? Because we did not know. And it was just hopelessly uncertain. But he was crossing state lines, and troopers had to go find him. And it was just one of those things where the public health right thing to do was to be cautious and open with the individuals involved and tell them what was going on. But the information involved so many people that there was a sense that we need to get ahead of it, because somebody's going to go to the press about this. But a couple of us fought really hard for the headline of the press release to have the word possible in it, which kept getting removed. And then we kept putting it back in and kept getting removed, because we really didn't know if it was a real case or not. It was a lab test that didn't have high certainty. So we still got ridiculed all over the place because he didn't end up having it, which was good that he didn't have it, but for just going out and making a big deal out of it. But at least we got the word possible in there. So not really a lesson. It's just to say, to keep the uncertainty in there when, being overly certain will come back to haunt you. And it doesn't help the people who are trying to take precautions either. So, yeah, okay. One more question. Oh, okay, there's right behind you. Yeah.
This is a follow-on about uncertainty. In the last week, Bill Gates has been quoted a lot in the press about saying he's very uncertain about the emergence of a pandemic. I expected someone else to pick this up today, but
Yeah.
can you comment on, I mean, I think that, for example, that the people gain new confidence with the response to Ebola. And yet here we have someone who's so widely respected and knowledgeable and maybe is trying to influence the resources. I'd love your thoughts about that. I know it's okay.
Yeah. So he gave the Shattuck lecture across town earlier this week, or Friday, and did a lot of press around it. And I think what he was saying was, he's certain there's going to be a pandemic. We're all certain there's going to be more pandemics. But while he's optimistic and confident that science and technology and public health are going to continue to improve child health, we've halved child deaths in the past, 15 years or so, and he's really optimistic and confident about those solutions. He is not confident that we have the public health response to be able to deal with a pandemic. So I think he's not talking about the uncertainty of the event. He's talking about we have not been putting enough into this problem. And so he's announced a grand challenge about, universal vaccine, whether we can get there or not, and I think is really trying to reinforce the need to invest in public health capacity. He's a big one on technology, but he's not sure technology is going to get there. So we need to do more than just count on technology. So I agree with him.
Please join me in thanking Dr. Schuchat, and there's a reception at the back now. And for any